Hi, I'm Debbie Levine. I'm a professor of radiology at Beth Israel Deaconess Medical Center and Harvard Medical School. And today I'm going to be talking about ultrasound of skeletal abnormalities. Hello, today I'm going to be talking about prenatal diagnosis of skeletal abnormalities. Now, when we do obstetric ultrasound, probably the most common thing that we'll see is a short humerus or short femur. So I'll be talking about those, particularly with respect to Down syndrome. But then I'll also be talking about abnormalities such as polydactyly, scoliosis, amputations and amniotic band syndrome, sacrococcygeal teratoma, positional deformities, for example, club feet and clenched fists, and then finally, skeletal dysplasias. So let's start with the short humerus and short femur. These are both sonographic features of trisomy 21 or Down syndrome, and there are many different definitions for what comprises one of these short so-called long bones. It can be based on the observed over expected length. It can be less than the 5th percentile for gestational age, or less than some number, usually around 0.9 multiples of the median. When you get one of these numbers, you take a patient's pretest probability and look at the likelihood ratio of Down syndrome. And it turns out that that likelihood ratio is higher when there's an abnormal humeral length than when there's an abnormal femur length. All right, so when we look at likelihood ratios, and there have been a number of different studies, I just have 4 of them up on this slide, you can see that there are a number of different likelihood ratios for abnormalities that we might see in the second trimester. For example, nuchal thickening has a likelihood ratio that's very high, as does echogenic bowel, but short humerus and short femur are much lower, as low as only 1.2, and therefore these aren't very strong predictors of Down syndrome. Another problem is that the false positive rate, for example, with the short femur is as high as 20%. And you can imagine there are some populations of people that are just normally shorter than others. For example, the Asian population, you really can't use a short femur length. Now, it turns out that there are some hints we can use when we look at the dating sheet to figure out if a short femur is important or not. For example, in this particular patient, the femur is measuring 19 weeks, 5 days, and the biparietal diameter, 21 weeks, 2 days. The age by dates is 20 weeks, 6 days. And it turns out that in Down syndrome, they tend to have a slightly rounder head, meaning a bigger BPD, and again, the short femur. So what are our recommendations if we see a short humerus or a short femur? Well, if it's isolated, if other testing is negative, and if the pretest probability is low, these can likely be ignored. When you see a shortened bone, though, you want to make sure that it looks morphologically normal. And so you look at the morphology. And then you need to remember that a short and long bone could indicate a fetal growth abnormality. And so you're probably going to get follow-up later on in gestation. There's been an increase in intrauterine growth restriction that's been noted following an isolated short femur or short humerus. And therefore it's reasonable to get one follow-up ultrasound in the 3rd trimester. All right, now here's a patient who had a short femur and also has hydrops. I say there's hydrops because there's skin thickening, there's a pleural effusion, and there's also this abnormality that we see pooching out just above the cord insertion site of big omphalocele. And here's her short femur, 14 weeks. Age by dates is 16 weeks. The abdomen here is measuring fairly large because, again, of all that soft tissue edema. So this kind of finding, when there's a short femur and other abnormalities, should really make you think of a chromosome problem. And here you can see that there's a cystic hygroma, big loculated fluid collection behind the neck, even extending down the back. So we're going to think about a chromosome abnormality in a patient like this. Well, let's now move on past the short humerus and short femur and go to polydactyly. Polydactyly is when there are too many digits, and usually instead of 5 digits on an extremity, there'll be 6, although you could have more. So here we can count, there's a thumb, 1, and there's the 2nd, 3rd, 4th, 5th, and here's a 6th digit. Now 3D ultrasound can be helpful to look at this, but basically you need a good 2D picture in order to get a good 3D picture. And here's a postnatal radiograph showing you that sometimes this extra digit is not completely formed. Sometimes it doesn't even have bone within it. And this also tells you that it can be fairly easy to remove after a baby is born. The surgeons can just so-called lop off that little extra digit. But what's important is to figure out the familial recurrence of this, the familial incidence, and also know about the syndromes that can happen with this. So you need to figure out which side of the hand this extra digit is on. Is it on the thumb side or is it on the ulnar side? Preaxial is the thumb side, that's usually sporadic, and postaxial is on the ulnar side, and that's usually either familial or syndromic. So if you see that extra digit, you figure out which side it's on, you talk to the parents about whether there's any family history of extra digits. Well, our next main topic is scoliosis, and scoliosis is when there's a bend in the spine. And usually, if we can see this prenatally, it's a fairly severe scoliosis. You're first going to think about a vertebral abnormality, and if there is a vertebral abnormality, you'll think of the Vater association, and that stands for vertebral, anorectal, cardiac, tracheoesophageal fistula, radial ray anomalies, and limb atresias. Sometimes people put chromosomal abnormalities in that Vater association as well. You can also see scoliosis with neural tube defects, and you can also see it with amniotic band syndrome. So you want to look very carefully at basically the entire fetus whenever you see an abnormal bend in the spine. So here, for example, we have a fetus with a really acute angle scoliosis. You count which lumbar vertebral body it's at, and in this case, it's at about L3. And there were splaying of the posterior vertebral elements. You can see this here. That will make you think of a neural tube defect. But we didn't see any sac here. Now, not all neural tube defects need to have a sac. And you can clearly see here that these bones are extending right out to the skin on this 3D reconstruction. And this was indeed a neural tube defect. Now, here's a very, very curved spine. No normal fetus would have a spine curving side to side like this. In fact, we're getting an image of both the chest and the abdomen in the same image. That's how curled up this fetus was. And you could actually see unattached amnion here. So this is a classic example of amniotic band syndrome, but the really severe form of amniotic band syndrome, which is also called limb body wall complex. When you have limb body wall complex, you might have a head abnormality, such as exencephaly or an encephalocele, and these won't be your usual midline encephaloceles, these will be off midline. You might see facial clefts. You might see breaks in the abdominal wall or the thoracic wall, the so-called thoracoschisis or abdominoschisis. You can see limb defects, scoliosis, and because the fetus can't move normally, you get a short umbilical cord. Now, this is very different, the limb body wall complex, from a more isolated amniotic band syndrome where you have limb reduction defects. And here, for example, we're looking at an upper extremity and it comes to an abrupt halt, and you're not seeing a hand at the end of this extremity, and the long bones, when you measure them, are slightly short. Here we can see a fetus with amniotic band syndrome where one hand looks normal, and you can see an open hand and the fingers spread out here, but the other hand you can see one of these limb reduction defects with an absent hand. Sometimes you'll just see a shortened humerus. For example, here the humerus just abruptly ends. It's too short, and you can see the defect in the skin here. And you can almost imagine what's happened here in that an amniotic band has been tightened around an extremity here. It's cut off the blood flow, and the more distal extremity has just kind of melted away. Sometimes you'll actually see that band, and here we can actually see that band of tissue going across this lower extremity. So this is the more proximal portion of the extremity. This is the distal portion, and you can imagine the arterial flow was coming in, the venous flow couldn't get out, so the tissue distally becomes very edematous before it kind of melts away. And you can actually see the kink in this long bone from that constricting band. Well, the next topic after amniotic band syndrome is sacrococcygeal teratoma. Of course, we want to differentiate a sacrococcygeal teratoma from a neural tube defect. And the big difference is that when you look at the spine posterior elements are normal. Sometimes if a sacrococcygeal teratoma is large enough, it will actually push up against the vertebral bodies and make the anterior portion of the spine be deformed. Here we're seeing a large cystic sacrococcygeal teratoma. Here we're seeing one that's both cystic and solid. And it's really important when you see one of these masses at the base of the spine that you look for how many internal organs are affected. Is there any obstruction, for example, of the bladder or of the GI tract? But also, how vascular is it? Because it's the amount of vascularity that will determine whether a fetus is at risk for developing hydrops. And here we can see on this color Doppler and pulse Doppler that there's a little bit of blood flow in that solid element, but not much. Now, it can be very, very hard to tell how much of these sacrococcygeal teratomas are actually intrapelvic, in the pelvis itself. And that makes a difference for how we counsel the patient as far as the surgery and the expected outcome postnatally. So in those cases, it can be very helpful to get an MRI. And here we've got an MRI showing the spine. Here's the thecal sac, and here's the sacrococcygeal teratoma with just a very small part extending into the pelvis. Now, when these teratomas are predominantly solid and very, very vascular, that's when they can cause hydrops, and they can also cause the mirror syndrome, where the mother gets ill as well as the fetus because of the hydrops. Here's a classic diagram for how we grade these different sacrococcygeal teratomas depending on their intrapelvic extent. This is described in pediatric patients, but it's the same description that we use in the fetuses as well. Well, let's now move on to positional deformities. And when you can get a beautiful hand like this waving hello, it's very reassuring, both to the parents and to the sonographer, that the hand is there and that the digits are there and that the fetus is moving normally. Of course, you want to see both hands on both sides looking normal like that. Similarly, a normal view of the feet is when you can get this hang 10 appearance. If you can get the bottoms of both feet lining up like this and see all 10 toes, then you know that there's not a positional deformity of the feet. It just wouldn't be able to look like that. So those are very reassuring signs. In contradistinction to this is the clenched fist. And the clenched fist is classically seen in trisomy 18. Here you can see a fetus also has ventriculomegaly. But these clenched fists, we can't even show how we would hold a fist in this position, because not only are the fists closely tightened, but they also have overlapping digits, as you can see here. Rocker bottom feet are harder to illustrate sonographically, so instead I have this image that was taken from Dr. Chudley from the Department of Pediatrics and Child Health at the University of Manitoba, and it shows you the nice rocker bottom feet that you'll see in a fetus with trisomy 18. So here are the findings in trisomy 18. There's a great big laundry list of findings: second trimester growth restriction, polyhydramnios, heart disease, hernia, omphalocele, but it's the limb malformations that I'm talking about here: clubfoot, rocker bottom foot, arthrogryposis, which is where the extremities are just held at an awkward angle and don't move normally, and then the clenched hands with the overlapping digits. Now, when we see a clubfoot, there are a lot of different things that we'll think about. Clubfoot neural tube defect should jump to mind. You want to do a good job looking at the spine and at the posterior fossa. But it's another one of those abnormalities where you might want to get a family history, because sometimes there'll be a family history of clubfoot and the parents will very well know that either it's easily correctable or they had to wear a brace for a while in childhood. You want to look very carefully at all of the brain, since brain abnormalities are associated with clubfoot. But realize sometimes there can be a positional deformity, especially if there's oligohydramnios. Now in this case, the fluid is normal. The foot is up against the edge of the uterus. You'd want to move the pregnant woman around and make sure that no matter how she's turned and where this lower extremity is, that the foot is constantly held in that abnormal position. Here are two more examples of club feet. Now, some people really like 3D ultrasound to demonstrate these abnormalities, but again, you have to first see it in 2D to understand that the abnormality is actually present before these 3D reconstructions can really be helpful. But here, when you have abnormal positioning, and this is getting to that arthrogryposis type of case, Again, the 3D can be very helpful. It can be sometimes difficult to get an entire extremity on a single 2D view, and when you get that 3D, it can really be helpful. And in a case like this, it really helps you understand the anatomy better. You've got kind of a foreshortened humerus, definitely radius and ulna are almost absent, and then you've got these hands held at an awkward angle. This is a very unusual position, and it should really make you think of a syndrome and not just one of these amniotic band syndromes. It's not just a reduction defect. This is something more than that. This is both a reduction defect and abnormal positioning, and the thing to think about there is Holt-Oram syndrome. Now, when we're talking about skeletal abnormalities, many of these different appearances will have many different potential etiologies, but looking for the associated abnormalities can be helpful. For example, in Holt-Oram syndrome, there frequently is congenital heart disease, ASD, VSD, endocardial cushion defect, but you can also have these abnormalities of the upper limb, phocomelia, radial rheoplasia, a triphalangeal thumb, and clinodactyly. Which brings us to what you probably thought this whole talk was about, skeletal dysplasias. When we talk about abnormalities of the skeletal system, that's what people first jump to, but actually many of these other abnormalities, the positional deformities, the short humerus, short femur, are much, much more common than these skeletal dysplasias. So you always want to make sure that you look at the long bones, see what they look like, see if they look morphologically normal before you jump to a skeletal dysplasia. Prenatal diagnosis is very, very difficult for skeletal dysplasias. There's 150, probably even more different skeletal dysplasias. And we can actually do some genetic testing for some of these, particularly if patients have a known family history with a known congenital abnormality that can be tested for with genetics. So frequently there's molecular testing available, and it can also be helpful to plan at delivery. It's also important when you diagnose a skeletal dysplasia to have a complete evaluation at birth. And if a family is planning to terminate, and if it's going to make a difference in a future pregnancy, then you can actually do some tissue sampling for testing and accurate counseling for recurrence risks. So let's look at a classic skeletal abnormality. The patient comes in and her age by dates is 20 weeks, 3 days. Look at this BPD, 22 weeks, 3 days. So the BPD, again, it's a round head. It's too big. And very, very short femur, 14 weeks. This is not the slightly short femur that you see with Down syndrome. This is a severely short femur. And because it's so short so early, all of those other abnormalities that I kind of say, well, just check growth later, they all disappear. This is going to be a skeletal dysplasia. It's just way too short, way too early. So you look at these long bones and they're very, very short, and you know that this is severe micromelia. You look at the head and it's very, very round. Now there's some other findings that can be a little bit more difficult. One of those is this very wide iliac angle. Normally when you're looking at the distal spine, you can see these nice posterior elements pointing towards each other here, but you don't have those iliac wings so widely splayed apart. But what's really important when you see one of these early severe abnormalities is to look at the chest size. Because even if we have trouble figuring out exactly what the prenatal diagnosis is, figuring out if it's lethal or not is going to be very, very helpful in counseling. And the lethal dysplasias are those that have a small chest size. So here we are at only 20 weeks. The thoracic circumference is the 5th percentile for gestational age, and these ribs are very short. And a lot of these skeletal abnormalities that are lethal do have short ribs and do have a very, very small chest. And so you can imagine if a baby were to be born with this abnormality, that the baby would have difficulty breathing because the lungs haven't had enough room to grow normally. You can actually see that there's skin thickening here as well. Less important, but a nice illustration here, are these short, stubby fingers. So I've shown you a lot of images in this case, and just give you a second to think about. We've got kind of a round head. We've got a very, very small chest. We've got very, very short, long bones that are obvious early in gestation. And the classic diagnosis is Thanophoric dysplasia, the death-loving dysplasia. And this is important, again, because it's a lethal skeletal dysplasia. And I've got images from another fetus here with the same diagnosis. The recurrence risk, it's nice to know for when you're talking to parents, is not significantly higher than the general population. And if you're in a location where you can have DNA-based prenatal diagnosis, you can definitely offer that. So here's another case. You've got the short ribs. Here we've got the so-called telephone receiver femur, where it's short and stubby, but it's got the flared metaphyses. And on this image, you can see the short ribs and the skin thickening. Here's an image of a neonate with the Thanophoric dysplasia. And again, you can see the big head and the very, very small chest and the short, long bones. The incidence, it depends. If you're counting in utero or postnatal, maybe about 1 in 8,900, classically described as having that prominent forehead and the depressed nasal bridge. There's a long differential diagnosis. And basically, knowing every one of these different things is not as important as looking and assessing for that lung size and saying that this is a lethal abnormality. So here, for example, is a chest x-ray of a neonate with Thanophoric dysplasia. See the small chest, see all the skin thickening, and obviously this baby died. There's no aeration in the chest at all. Here's that classic telephone receiver femur. And that's the type 1 Thanophoric dysplasia. What a lot of people don't recognize is that there's a type 2 Thanophoric dysplasia where the femur is straight, and then you might get the cloverleaf skull. Well, let's move on now to heterozygous achondroplasia. And it turns out that of the neonates that survive, when they're diagnosed in utero, those that survive, this is going to be the common one. This is the dwarf that you might see walking around. So here's an example of a case. A fetal survey was normal at 21 weeks, totally normal, and additional imaging was requested at 30 weeks. So here's the date sheet at 21 weeks. Age by ultrasound was 20 weeks. All of these parameters are right about 20 weeks. So she's just off by a week, and that's basically normal. There's no problem with that. You look at 31 weeks, and here's a femur. It's still straight, but it's now starting to drop off the growth curve. If you look at this date here, it's 27 weeks, 6 days, whereas her age by dates is 31 weeks, 5 days. So it's now about 4 weeks behind. And this is pretty classic for for heterozygous achondroplasia, where it looks normal early and starts to drop off the growth curve at about 27 weeks. You look at the chest here, and the chest size is normal. There was Polyhydramnios, and another finding was nicely shown because of the Polyhydramnios, the so-called Trident fingers. I would never use Trident fingers to make the diagnosis of heterozygous achondroplasia, but it's an ancillary finding. And then you've also got the so-called frontal bossing, and here you can see a little bit of the prominent forehead here, and here with the Polyhydramnios. Now, I don't do a lot of plain film in pregnancy. They used to do a lot more of it. You can do it to look at the shape of the long bones, but really we don't want to expose neonates to or fetuses to ionizing radiation. So this is infrequently done prenatally, although definitely after the babies are born, they might do that to help establish a diagnosis. But this is nice to show what you might see if a radiograph were done. Narrow thorax with short ribs. Another radiographic finding is the short skull base. You can have the small square iliac wings, posterior scalloping of the vertebral bodies. It turns out that the interpeduncular distance of the lumbar spine of vertebral bodies decreases from L1 to L5 instead of the normal increase. And that's why these children and then adults can often have spinal stenosis later in life. Here's an example of this neonate, the same one I showed you before, with this kind of rounder head, the frontal bossing, the trident hands, and they'll also have those widely spaced nipples. Well, here's another case, and this one I'll be showing you is a little bit of an unknown. Really, really severe micromelia showing up at a very early gestational age. In this case, the gestational age is 17 weeks. The femur length is measuring 13 weeks. So it's an early diagnosis. It's hard to even tell that that's a femur length. Really, really hard to see. When you look up at the head, there's decreased mineralization. And this is a really important finding. How do I know there's decreased mineralization? Well, normally it's pretty darn easy to see the downside choroid plexus and ventricle. It's harder to see the upside choroid plexus and ventricle. And that's because normally the skull is ossified and you get shadowing behind the ossified skull. But here we're seeing both sides of the brain equally well. That's how we know it's a demineralized skull. So here we're seeing the skull all the way around, but it's not ossified. Beautiful look at the intracranial anatomy. We look at the chest, and it's a little bit small. And look at these ribs. They're bent. And here, when we look at the ribs, they have kind of a wavy appearance. So think about it. What's your differential diagnosis? There's very, very severe micromelia, and there's poor ossification. There's really only two things we think about in this instance. Osteogenesis imperfecta is the one that first pops into mind, and then hypophosphatasia. And the reason it's important to think about both of those is that osteogenesis imperfecta has a 5 to 7% recurrence risk. It's not just that it is genetically inherited, but there are also phenotypic differences. Hypophosphatasia, autosomal recessive, has a 25% recurrence risk. However, either way, as an ultrasound person, you're going to recommend that in the next pregnancy that the patient gets screened early on. So here's a case, 23 weeks with short long bones, and we can see broken bones everywhere. Really classic broken bones here. Here you can see a bone that looks straight, and then you see the break and another broken bone right here. By date, she's 23 weeks. Her femur length, because of these breaks, is measuring 20 weeks. You look at the chest and you see all of these broken bones. Look at the ribs, broken bones everywhere. Very wavy appearance of the ribs. And when you look at this chest, you can see how deformed and abnormal it is because of all the broken bones. But when you look up at the head, the ossification doesn't look as bad as that prior case that I showed you. And again, that's because of the phenotypic differences. You can still have osteogenesis imperfecta and still have some ossification, but just a different kind of appearance and a different time of presentation of all of the broken bones. But again, this is osteogenesis type 2, and the thoracic circumference in this case was small. Here's a different case of osteogenesis imperfecta, and again, you can see that this fetus, then neonate, did not survive. We're not seeing aeration in the lungs. The bones are all broken. The ribs are broken, multiple fractures seen in the long bones that are very deformed. Now, there are many different types of osteogenesis imperfecta, and personally, I don't think the different types are that important to know, but some understanding of the presentation and the phenotypic variability is important to know about. The type 1 might be born and not have fractures until later on in life when they just have easier than normal fractures. They can actually have normal stature. The type 4 is also a milder form, short stature, and variable age of onset. The type that we tend to see in utero is the type 2 when we have that extreme bone fragility leading to either intrauterine or very early infant death. So here we've got an example of a plain film of a fetus who did not survive with osteogenesis imperfecta. And again, you can see the very, very short long bones and the poor ossification of the skull and the very, very small chest. Well, just because a bone looks bent doesn't mean it's broken and doesn't mean it's osteogenesis imperfecta. And I had to learn this the hard way. Here we've got what looks like a bent bone in a fetus that ended up being diagnosed with Campomelic Dysplasia. So just be a little bit careful about how definitively you make these diagnoses. In Campomelic Dysplasia, though, you won't see broken bones everywhere. You tend to see this appearance in the femur. Another abnormality that can be diagnosed in utero is achondrogenesis. And here I've got a case of achondrogenesis. We're looking at normal ossification of the skull, but we're seeing a large amount of soft tissue in the nuchal region with some fluid collection. In this case, we're seeing a very, very small chest. Look at how small these ribs are. The heart is big in the chest and looks deformed as well. But there's very, very severe micromelia. Look at how small these long bones are. Very tough diagnosis to make. In this case, we would really end up saying that this is some type of lethal skeletal dysplasia, and we're not quite sure what. In this case, we actually had to do a vaginal scan in order to better define what bones we were seeing and what bones we were not. There was so much subcutaneous edema, and this was a very early termination of pregnancy because basically this was not going to be compatible with life. And here you can see that there's absent ossification of the spine and pelvis, bowing of the long bones with metaphyseal cuffing. So I've shown you probably too many skeletal dysplasias, but what I'd like to leave you with is an idea that there's lethal anomalies, and then there are anomalies that can have variable outcomes. So the lethal anomalies, the Thanophoric dysplasia is going to be the one we see most commonly in utero, with an incidence of about 1 in 10,000. Achondrogenesis is also autosomal recessive, maybe 1 in 40,000. The osteogenesis type 2, I've shown you a lot of cases, and that's because we can diagnose that pretty easily when we see those long bones that are broken. But the incidence, it turns out, is only about 1 in 60,000. Now, heterozygous achondroplasia, you might say, how come that's the one I see most commonly walking around? And the answer is because that's the one that's compatible with life. It's not one of these lethal skeletal dysplasias. So I've shown you these, and I've shown you some ways that we can make the diagnosis, or at least suggest the diagnosis, but I want to tell you that we're not that accurate. And if you look at a number of different studies, they report accuracy in the range of about 50%. And some of these accuracy values are important because they can be changes in the genetic counseling after a final diagnosis. So a study by Gaffney in 1998 said that these abnormalities and these changes in diagnoses were more frequent for Thanophoric dysplasia and osteogenesis imperfecta than for specific features, and that rare diagnoses were more likely to be accurate. And that in 20% of the time, a specific diagnosis couldn't even be made postnatally, despite full pathology and an expert referral. So you can imagine if 20% of the time we can't make the diagnosis when we've got a baby in front of us, how much harder must that be in utero? So in conclusion, antenatal ultrasound is excellent for discovering lethal skeletal dysplasias. We look at the clinical exam, x-rays, autopsy. We have multidisciplinary postnatal assessment, all being important for our most accurate specific diagnosis. And then if you're in an area where storage of tissue and genetic testing is available, that's very important for future testing for prior pregnancies. Well, those are my conclusions for the skeletal dysplasias. But I also want to just bring you back to prenatal diagnosis of the skeletal dysplasias. And there, our first question is it lethal? Look at the thoracic circumference and look at the associated features such as hydrops. What about the pattern of the affected bones? Is it everywhere, or is there just a focal limb shortening? And if there is some limb shortening, is it angulated? And then remember that the final diagnosis might not be known until after birth, and that a specific diagnosis will aid in genetic counseling, and that recurrence risks will change if your diagnosis changes in about 50% of the cases. Thank you.